All right, welcome back to the deep dive. If you're in the thick of it, preparing for your MD anesthesiology exams, you know the score. It's not just about the shiny new drugs.
Not at all.
It's about mastering the foundations, those benchmark agents that, well, they're pretty much guaranteed to show up on your exam paper.
Exactly. And today, our mission is very focused. We're zeroing in on one of the most important foundational agents, halothane. We're going to synthesize everything you need: the pharmacology, the clinical side, and most critically, the complications. We're actually structuring this whole deep dive to be the perfect high-scoring answer you'll need to deliver.
And we're pulling this from all the core texts, really distilling it down to the high-yield facts, the connections you need to make. Because, let's be honest, you need to understand halothane, not because you'll use it every day.
Probably not, no.
But because its toxicology, its whole profile, really defines the safety standards for every single volatile agent that came after it. It is the key to comparative pharmacology.
It absolutely is. So let's start by framing this for the exam. Let's get the definitions precise right from the get-go.
Okay.
Halothane is fundamentally a halogenated alkane derivative, and that chemical class distinction is important. It's an alkane, not an ether, like the modern agents.
Right.
Physically, it's a clear, non-flammable liquid at room temperature. It's volatile, and it has this distinctive, sweet, almost bland smell.
And its history is just, it's pivotal. Synthesized in 51, brought into clinical practice in 1956. This wasn't just another drug, was it? This was a revolution.
Oh, it was a complete game changer. And it changed practice because it fixed two huge problems with what came before it. Things like ether and chloroform.
What were those?
First, safety in the OR halothane was non-flammable and non-explosive. Ether was, notoriously dangerous, especially with biothermia in use. And second, it dramatically improved the speed of everything, the speed of induction, and just as importantly, the speed of recovery.
And we can actually put a number on that leap, can't we?
We can. You just have to look at the blood. Gas partition coefficients, it tells the whole story. Ether had a coefficient of 12.1, incredibly slow.
Wow.
Chloroform was a bit better, but still way up there at 10.3. Halothane brought that number crashing down to around 2.3 to 2.54.
So that's the shift.
That's a shift. That move to intermediate solubility was the crucial step. It really paved the way for the faster modern agents we use today.
Okay, so if it's been largely phased out, at least in a lot of places, why do examiners still hammer us on halothane in the theory papers and the Vivas?
Because it's the benchmark. It's the standard against which everything else is measured, especially for toxicity and kinetics. You simply cannot appreciate the safety of isoflurane's low metabolic rate without knowing halothane metabolized up to, 46%.
Right, it gives you the context.
It gives you all the context. You have to understand halothane's dose-dependent myocardial depression to really get why its successors were such an improvement. Its flaws literally define the safety requirements for modern agents.
So what are the specific questions we should be prepped for?
Okay, be ready for a direct, long-form question. A 20-mark essay on the pharmacology and complications of halothane. That's a classic.
And short notes.
Short notes are also very common. Things like defining MEC and all the factors that influence it. The two types of halothane hepatitis, you have to know the pathophysiology for both. And inevitably, a comparison with newer agents like isoflurane and sevoflurane.
Okay, let's dive into the chemistry and physical properties. These numbers are non-negotiable. You have to have them memorized. The structure, 2-bromo, 2-chloro, 1-vord, 1-vord, 1 trifluoroethane. That's a mouthful. What's the point of all that halogenation?
Well, that complex structure is where its revolutionary properties come from. Specifically, it's the multiple carbon-fluorine bonds. They're incredibly strong, and that's what makes the molecule non-flammable and non-explosive.
That's the safety factor.
That's the huge historical safety factor. And then, conversely, the presence of that single hydrogen atom, plus the carbon-chlorine and carbon-bromine bonds, those are what contribute to its anesthetic potency.
What about storage? This is one of those little details that's easy to miss but can get you points.
A critical exam detail. Halothane can actually decompose on its own, especially with light or oxygen. It forms volatile acids, hydrochloric, hydrobromic acid, and even phosgene gas, which is obviously very dangerous.
So how do we prevent that?
It's stored in amber-colored bottles to block the light, and it contains 0.01% thymol as a preservative.
And the thymol itself has an implication, doesn't it?
It does. Thymol does the job, but it's not volatile. So over time, in some of the older vaporizers, this sticky thymol residue can build up.
And that can affect the machinery.
Precisely. It can jam up the moving parts of the precision vaporizer, the turnstiles, or the temperature compensating bits, and that could lead to inaccurate delivery, which is dangerous with an agent this potent.
Let's get to the key numbers. First up, volatility.
Okay, so volatility tells us how we deliver it. The boiling point is low, 50.2 degrees C. That means its saturated vapor pressure, or SVP, is high at room temp. It's 243 mmHg.
And that's why it needs a special vaporizer.
That is exactly why. It requires a specific temperature-compensated precision vaporizer to deliver it safely and accurately.
Next, solubility. This is all about speed.
Right. The blood gas partition coefficient is the key here. For halothane, that number is around 2.5. We call that the intermediate zone.
What does that mean clinically?
It means induction is pretty smooth and pleasant. The concentration in the lungs doesn't rise too fast, so it doesn't irritate the airway. But it is noticeably slower than modern agents like sevoflurane, which has a coefficient of 0.65.
So the blood kind of soaks it up for a while. What about potency?
Potency is all about how lipid-soluble it is, which we measure with the oil-gas partition coefficient. Halothane has a high value here, 224.
And high lipid solubility means?
High potency. That's the Meyer-Overton theory. They're directly related.
Which brings us to mmHg.
Exactly. Because it's so potent, its minimum alveolar concentration, or MOC, is low. For a standard adult, it's just 0.75%. Compare that to isoflurane at 1.15% or sevoflurane at 1.8%. Halothane is a very potent drug.
Okay, let's put all that together. What are the quick exam-ready takeaways on these properties?
3 things. First, intermediate BG of 2.5 means intermediate onset and recovery, good for mask induction.
Okay.
Second, the high OG of 224 and low MEC of 0.75% means you must use a high precision vaporizer. Accuracy is everything.
And third?
Third, its high lipophilicity means it dissolves in rubber and plastics. This is a big deal if you're trying to have an anesthetic-free circuit, maybe for a patient with malignant hyperthermia risk. The halothane will keep leaching out of the rubber parts for hours.
Let's move on to the mechanism of action. Now, this is a tricky area, but what's the current examiner-approved theory? We've moved past the idea of it just dissolving in the cell membrane, right?
We have. That historical view was foundational, but the science has evolved. The correlation between potency and lipid solubility, the Meyer-Overton rule, still holds true, but we now believe the primary action is binding directly to specific protein targets.
And where are these targets?
Well, this is a key distinction. The effect that we measure for MS, the prevention of movement in response to surgery, that is mediated primarily in the spinal cord.
So MS is a spinal effect, not a brain effect.
Principally, yes. The hypnosis and sedation parts are definitely happening in the brain, but the immobilization that defines MS is largely spinal.
And what's the molecular action that's causing all this?
It's mostly about enhancing inhibitory synaptic transmission. The main target is the GABA receptor. This is the primary off switch in the central nervous system.
And halothane flips that switch.
It potentiates it, it binds to a site on the GABA receptor, and it increases the duration that the chloride channel stays open.
Okay.
So more negative chloride ions flow into the neuron for longer. This hyperpolarizes the cell, making it much harder for it to fire an action potential. It basically strengthens the off signal throughout the CNS. It is the same thing with lysine receptors, which are also very important in the spinal cord.
Tying this back to kinetics, how does that intermediate solubility of 2.5 affect the speed at which this happens clinically?
This is fundamental. The depth of anesthesia is all about the partial pressure of the agent in the brain. And because the brain gets so much blood flow, its partial pressure quickly matches what's in the alveoli, the P-alv.
And the blood. Gas coefficient controls how fast that P-alv goes up.
Precisely. Because halothane has a BG of 2.5, the blood acts like a big reservoir. A lot of halothane has to dissolve into the blood first before the pressure in the lungs and therefore the brain can rise high enough to cause anesthesia.
So that uptake slows everything down.
It slows everything down compared to an agent like disflurane where the blood is barely a reservoir at all and the P-alv just shoots right up.
Okay, let's trace halothane's journey through the body pharmacokinetics. Uptake and distribution first. We know it's super fat soluble. How does that play out over a long surgery?
It's a huge factor. The distribution is complex. We talk about a 5-compartment model: lungs, vessel-rich organs like the brain, muscle, and then 2 different fat compartments.
And because it's so lipophilic?
It just loves to accumulate in those fatty tissues. Over a long case, they become saturated with halothane.
Which has a big impact post-operatively, I imagine.
A massive impact. It means elimination isn't quick. The agent slowly leaches back out of the fat into the blood and then gets exhaled. This can go on for 24 to 48 hours after the case is over.
So the patient's total drug exposure is much higher.
Much higher, and that has major implications for its metabolism and potential toxicity.
And what about ventilation? How does that affect the kinetics?
Well, halothane is a potent respiratory depressant. So if your patient is breathing on their own, their minute ventilation will drop. This slows down the rate of uptake during induction, making it even longer.
And it slows down recovery, too.
Exactly. It slows the rate of washout. It's one of the main reasons controlled ventilation is generally preferred when using halothane. It just makes the kinetics more predictable.
All right, let's get to the most critical pharmacokinetic feature. It's metabolism. This is where all the warnings come from.
This is the absolute high-yield risk factor. Halothane is metabolized to an extent that is just, well, unheard of for modern agents. We're talking 20% to 46% of the entire absorbed dose gets broken down in the liver.
And for comparison,
Isoflurane is about 0.2%. Sevoflurane is maybe 2.5%. The high rate of metabolism for halothane is the single most important factor behind its toxicity.
this metabolism happens through the cytochrome P450 system. Can you break down the two different pathways, the oxidative and the reductive? This seems vital.
It is absolutely vital. You have two competing pathways in the liver. Under normal, well-oxygenated conditions, you get the oxidative pathway. This is done mainly by the enzyme CYP2E1.
And this produces?
This produces the main end product, trifluoroacetic acid, or TFAA. But the critical intermediate in this pathway is what causes the big problems.
Okay. And the second pathway?
The second is the reductive pathway. This one is favored under conditions of hepatic hypoxia, low oxygen in the liver, or just decreased liver blood flow, which, by the way, halothane itself causes.
A vicious cycle.
A bit, yes. And this reductive pathway produces different highly reactive metabolites that are directly toxic to the liver cells. This is what's behind the milder form of liver damage.
Understanding that split oxygenated versus hypoxic pathways is clearly the key to the whole toxicity story.
It is. The significance isn't just the sheer amount of metabolism, but the fact that the byproducts, especially from that oxidative pathway, can bind to proteins and trigger a catastrophic immune response.
Right, let's get into that. Pharmacodynamics, this is the heart of the essay. Let's start with the cardiovascular system. What is the halothane hemodynamic profile in 2 words?
Myocardial depression.
Simple as that.
Simple as that. Halothane causes a major dose-dependent drop in blood pressure, and this is almost entirely due to direct depression of myocardial contractility. It's a powerful negative inotrope.
So it's not just making the blood vessels relax, it's making the heart pump weaker.
Exactly. Total peripheral resistance doesn't change much. The BP falls because the cardiac output falls. At 2 IMASI, you can see CO and BP drop by as much as 50%. A 20 to 30 millimeter of mercury drop from baseline is very common.
And how does it do that at a cellular level?
It's all about calcium. Halothane messes with calcium homeostasis in the heart cells. It reduces the amount of calcium coming into the cell, and it also impairs how the cell stores and releases its internal calcium supplies.
Less calcium, weaker squeeze.
Less calcium, weaker squeeze. That's the negative inotropy. On top of that, it blunts the body's normal reflexes. So when the blood pressure falls, you don't get that compensatory increase in heart rate. In fact, you often get bradycardia.
Now for the biggest red flag.
Yeah.
Sensitization to catecholamines.
This is the most critical safety difference between halothane and the newer agents. It profoundly sensitizes the heart muscle to the arrhythmogenic effects of epinephrine, whether it's from an injection or the patient's own stress response.
Why does that happen?
It's a complex electrical problem. Halothane slows down conduction through the heart's electrical system. This creates the perfect conditions for reentry circuits to form, and those circuits are then triggered by the presence of catecholamines, leading to dangerous arrhythmias.
So what's the number? The one number every candidate has to be able to quote for the exam.
You have to state it clearly. Doses of epinephrine above 1.5 micrograms per kilogram should be strictly avoided. Going above that, especially if the patient is also hypercapnic, is asking for trouble.
Moving to the respiratory system, we already said it's a potent depressant.
It is. It causes rapid, shallow breathing. And the key point is that the drop in tidal volume is much bigger than the increase in rate. So overall alveolar ventilation goes down and the resting PaCO2 goes up.
And the actual drive to breathe is affected too.
Severely. It blunts the response to high CO2, and even more dangerously, the hypoxic driver safety net is pretty much gone at 1.1 mSc. It just completely abolishes it. The patient could be severely hypoxic and not increase their respiratory effort at all.
But it does have one big respiratory advantage.
It does. It's a very potent bronchodilator. It's excellent at relaxing bronchial smooth muscle, which made it a go-to for patients with asthma. The downside, though, is that it also depresses mucociliary function, increasing the risk of post-op chest infections.
Okay, cerebral effects. Crucial for neuroanesthesia.
Halothane is a potent cerebral vasodilator. It increases cerebral blood flow, or CBF.
And in a closed box of the skull, more blood flow means
More pressure. It carries a significant risk of increasing intracranial pressure, or ICP.
So what's the strategy if you have a patient with a brain tumor or high ICP?
You use it with extreme caution, if at all. And if you must, you have to use modest hyperventilation to cause hypocapnia. The hypocapnia causes cerebral vasoconstriction, which you hope will counteract the vasodilating effect of the halothane.
Let's talk about the liver again, but this time about blood flow, not metabolism.
This is a really key comparative point. Halothane reduces total hepatic blood flow, and it does this because it does not preserve the hepatic arterial buffer response, the HABR.
Remind us what the HABR is.
It's the body's protective reflex where the hepatic artery automatically dilates if flow from the portal vein drops. Halothane knocks out this reflex. So as cardiac output falls, liver blood flow falls right along with it.
And the newer agents don't do that.
Correct. Isoflurane, sevoflurane, they all largely preserve the HABR. That makes them much safer for patients with liver disease. This failure of flow with halothane is also thought to contribute to the hypoxia that drives that toxic reductive metabolism pathway.
And finally, uterine effects.
It's a potent uterine relaxant. This can lead directly to uterine atony. The uterus fails to contract after delivery, and that can cause a massive postpartum hemorrhage. This is a major limitation for its use in obstetrics.
After running through that long list of side effects, let's circle back to why it was the standard for decades. What were its main clinical uses?
First and foremost, inhalational induction. That sweet, non-irritating vapor made for a smooth, pleasant experience for the patient, a huge improvement over pungent agents like ether. After induction, it was used for maintenance, but because it's a poor analgesic and doesn't provide much muscle relaxation, it was almost always used with nitrous oxide or muscle relaxants.
But its real home was in pediatric anesthesia.
Absolutely. For years, it was the king of pediatric mask induction. Kids tolerate it well, and it's much less traumatic than trying to get an IV in an anxious child. And critically, the severe form of liver toxicity is much, much rarer in prepubertal children than in adults.
Now, what about the MAC values in kids? That's a common Viva question.
Yes, it's not a straight line. MAC is actually lowest in neonates, around 0.9%. Then it peaks in infants at around 6 months of age, up to about 1.2%, before it gradually comes back down to the adult value.
And outside of pediatrics.
Its powerful bronchodilator effect meant it was a great choice for patients with asthma or reactive airway disease. And, because it's relatively cheap and easy to administer, it's still used in many developing countries today.
Let's quantify the dosage. Given its potency, how is it administered?
You need that specialized temperature-compensated vaporizer. You can't just drip it on a mask. Accuracy is key.
And what are the typical concentrations for the exam?
For a quick inhalational induction, you deliver a high concentration initially, somewhere between 2% and 4%. This helps to quickly saturate the blood. Then for maintenance, you dial it back to between 0.05% and 1%, especially if you're using other agents alongside it.
Okay, now the classic exam list.
Yeah.
Factors that change MA. What decreases the dose requirement?
Several things make the patient more sensitive. Increasing age is a big one. Hypothermia. Pretty much any other CNS depressant, you give them opioids, sedatives, you name it. And certain physiological states like hypotension, acute alcohol intoxication, and pregnancy.
And what increases MA? What makes you need more?
And that's a shorter list. Mainly hyperthermia and a state of high CNS catecholamines, like from cocaine or amphetamine use. It's also worth noting that chronic alcohol abuse increases MA, whereas acute use decreases it.
Before we get into the main event, the complications, let's quickly summarize the advantages that made it so popular.
Number one has to be its non-pungent nature. That sweet, non-irritating odor is the key.
And why is that so important clinically?
Because it allows for a smooth inhalational induction. With pungent agents like isoflurane, you get coughing, breath holding, laryngospasm. With halothane, it's a much calmer process. This was its killer feature, really, until sevoflurane came along.
Its potency is also an advantage.
A huge advantage. The low MAC of 0.75% means you only need a small amount of vapor. This leaves a lot of room in the inspired gas mixture for oxygen, which is always a good thing for patient safety.
And the other benefits.
Well, being non-flammable was the necessary first step, and that potent bronchodilator effect gives it a clear therapeutic niche in patients with reactive airways.
All right, this is the section that can make or break an exam answer. Adverse effects and complications. Let's start with the big one, Halothane hepatitis.
This is what you have to know inside and out. And you must describe the two distinct types. Let's start with type I.
The more common, milder form.
Exactly. Type I, or mild hepatotoxicity, is actually quite common, maybe seen in 20–30% of adults. It's just a mild, temporary rise in liver enzymes post-op. It's benign, it resolves on its own, and the patient usually doesn't even know they have it.
And the mechanism for type 1.
This is caused by that reductive anaerobic metabolism we talked about. It happens when the liver is hypoxic. This pathway produces directly toxic metabolites that cause a small amount of reversible cell damage.
Now, for the one that ended its career, type 2.
Type 2 fulminant halothane hepatitis. This is the catastrophe. It's rare, maybe 1 in 35,000 cases, but the mortality rate is horrific, up to 75%. This is massive liver necrosis, fever, jaundice. It's a disaster.
The mechanism here is completely different. It's immune-mediated.
Completely. This is a hypersensitivity reaction. It's triggered by the oxidative metabolism pathway. This pathway produces that highly reactive intermediate trifluoroacetyl chloride, or TFACl.
Yeah, and that's what starts the immune cascade.
Precisely. The TFACl binds to proteins on the surface of liver cells, creating a new structure called a TFA adduct. The body sees this as foreign, a neoantigen.
So it's a case of mistaken identity.
It is. In a susceptible person who has been previously sensitized, the next exposure triggers a massive T-cell attack against their own liver cells, leading to fulminant liver failure.
What are the key risk factors for type 2 that we must mention?
Number one is multiple exposures at short intervals, usually within 3 months.
Right.
This allows for that sensitization to happen. Middle-aged, obese women seem to be at higher risk, a family history, and of course, any prior unexplained fever or jaundice after a halogenated anesthetic.
And beyond the liver, what are the other major complications?
The high incidence of cardiac arrhythmia is due to that catecholamine sensitization, the very common dose-dependent hypotension from its negative inotropic effects, and then the two big systemic ones. It is a known trigger for malignant hyperthermia, just like all potent volatile agents. And its uterine relaxation can cause uterine atony and lead to a major postpartum hemorrhage.
Given that profile, let's nail down the contraindications and precautions. What's the absolute no-go?
An absolute contraindication is any history of unexplained jaundice or fever after a previous halothane or other halogenated agent exposure. There's a risk of cross-sensitization. The practical rule is to avoid repeat exposure within 3 months.
And for patients with liver problems?
You should really avoid it, especially since it doesn't preserve hepatic blood flow. It can just make a bad situation worse. The newer agents are much safer in this population.
What about for cardiac patients?
You have to be extremely careful. In patients with a poorly functioning heart or low blood volume, its negative inotropy can be disastrous. And the catecholamine issue means you can't really use it in cases where you need to inject a lot of local SUM with epinephrine.
Any specific drug interactions to flag?
Yes, be very wary of using it with other drugs that depress the heart, like beta blockers or calcium channel blockers. The effects are additive. And there's a classic warning against using it with immunophilin, which is associated with a high risk of ventricular arrhythmias.
And just to reemphasize the obstetric point.
Avoid high concentrations during delivery. The risk of uterine atony and hemorrhage is just too high. It's not a first-choice agent in that setting.
Okay, the comparison section. This is where you bring it all together. Let's put halothane head-to-head with isoflurane and sevoflurane.
This is a great way to structure a revision. First, the basics. Halothane is an alkane. The others are ethers. For speed, look at the Bg solubility. Halothane is 2.5 intermediate, isoflurane is 1.4 faster, and sevoflurane is 0.65 fastest.
And for potency?
Halothane is the most potent, with an MC of 0.75%, lower than isoflurane's 1.15% and sevoflurane's 1.8%.
What about the patient experience during induction?
This is where halothane had its historical edge. It's non-pungent and sweet. Isoflurane is very pungent, terrible for a mask induction. Sevoflurane is also non-pungent and pleasant, which is why it effectively replaced halothane for pediatric inductions.
Now for the critical difference, cardiac stability.
This is where halothane really falls down. It causes marked myocardial depression, a direct drop in cardiac output. And it has that maximum catecholamine sensitization. The newer agents are much, much kinder to the heart, far less depression, and virtually no sensitization.
And finally, the fatal flaw.
The liver.
It's all about the metabolism. Halothane, 20 to 46% metabolized. Isoflurane, 0.2%. Sevoflurane, 2 to 5%. That high metabolism is directly linked to the hepatitis risk. Plus, halothane drops hepatic blood flow while the others tend to preserve it.
So for the exam, the comparison must always come back to those 2 points.
Always. You have to stress halothane's maximum myocardial depression and its uniquely high hepatic metabolism. Those are its defining weaknesses. And then you acknowledge its one major strength, the non-pungent induction, which sevoflurane now does more safely.
Let's shift to the Viva. What are some of those tricky oral exam questions and common traps? Let's start with defining MA. Right. When they ask you to define a MAC, you need to be precise. It's the minimum alveolar concentration at which 50% of subjects do not move in response to a standard surgical incision. And you must add that the primary site of action for that immobility is the spinal cord.
And what about the related MSC values like IBS-bar or MSC-wake?
MC-wake is the concentration where 50% of people will respond to a command, usually about 0.3 to 0.5 ME. MAC-bar is the concentration needed to blunt the adrenergic response, the rise in heart rate and blood pressure to incision. It's higher than MSC.
The 2 types of hepatitis. That's a classic Viva trap.
A huge one. When they ask for the difference, you have to be crystal clear. Type I, common, benign, caused by reductive hypoxic metabolism. Type 2, rare, often fatal, caused by oxidative immune-mediated metabolism involving those TFA adducts.
What's a common mistake students make that you see all the time?
Forgetting the details about storage, the thymol, and the amber bottle. Mixing up the mechanisms for type I and type 2 hepatitis. Saying isoflurane is a good induction agent. It's not, it's pungent. And the big one. Not being able to quote the 1.5 microgram per kilo epinephrine limit, that's a major safety failure.
So what's a safe, top-scoring answer to have in your back pocket?
2 things. First, always mention that MSC values are additive. So 0.5 MSC of halothane plus 0.5 MSC of nitrous oxide equals 1 MSC. It shows you understand the fundamentals. Second, state that halothane's weaknesses, like poor analgesia, are compensated for by using it with other drugs like opioids or muscle relaxants.
What about presentation? Can drawing a diagram help in a written answer?
Absolutely. You don't need to draw a complex vaporizer, but a simple graph showing the Meyer-Overton theory is very effective. Just plot MSC on the y-axis against the oil-gas coefficient on the x-axis.
And that shows what?
It shows that clear inverse relationship. High lipid solubility, low MSC. It proves you understand the theory behind the numbers, which always impresses examiners.
And for a 20-mark essay, how should you structure it?
You have to weight your answer. At least 60% of your content needs to be on pharmacodynamics and adverse effects. Those are the most important sections. Start with a sharp definition, give the key numbers, and then spend the bulk of your time on the clinical effects and dangers.
And use clear headings.
Yes, underlined headings. Cardiovascular effects, respiratory profile, halothane hepatotoxicity, type I versus type 2. Make it easy for the examiner to see that you've covered all the key points.
This has been a very deep dive. Let's wrap it up with a tight, high-yield recap.
Okay. Halothane, a potent halogenated alkane, key numbers. BG around 2.5, MSC is 0.75%. Its big advantage was its sweet, non-pungent odor, which made it great for inhalational induction, especially in kids.
Its defining limitations are that marked dose-dependent myocardial depression and the profound sensitization of the heart to catecholamines. And you have to remember that safety limit, 1.5 micrograms per kilo of epinephrine.
And its infamy comes from its high metabolism, up to 46%, which creates the risk of fatal immune-mediated type 2 halothane hepatitis. That's the one triggered by the TFA adducts. It means you absolutely must avoid repeated exposures in adults.
Okay, let's fire up the top 12 take-home points for revision.
1. It's an alkane, needs thymol and amber bottles. 2. MAC 0.75%, BG 2.5, OG 224. 3. Works on GABA receptors, immobilization is spinal. 4. 20-46% hepatic metabolism via CYP2E1. 5. Drops BP and cardiac output by direct myocardial depression. 6. Maximum catecholamine sensitization, strict 1.5 mmHg Kg epi limit, 7. Great bronchodilator but causes severe respiratory depression, 8. Increases ICP by increasing cerebral blood flow,
Almost there.
9. Decreases hepatic blood flow because it doesn't preserve the HABR, 10. Hepatitis type 1 is benign reductive, type 2 is fertile immune, 11. It's an MH trigger and causes uterine atony, and 12. Used for pediatric induction, avoided in adults with repeat exposure risk.
That is a perfect revision list. Now give us a model conclusion paragraph for that 20-mark essay.
Okay. In conclusion, halothane remains a cornerstone of anesthetic pharmacology. While its clinical use has been largely superseded by agents like isoflurane and sevoflurane due to its unfavorable cardiovascular profile, specifically profound myocardial depression, and its unique risk of fulminant hepatic necrosis, its characteristics define the historical safety standard. Mastery of halothane's high metabolism rate, its failure to preserve hepatic blood flow, and the precise distinctions regarding its type I versus type 2 hepatotoxicity is essential for demonstrating foundational knowledge in volatile anesthetic safety and robust comparative pharmacology.
A very sharp conclusion. All right, here's one final thought for you to chew on as you study. We established that halothane dramatically reduces total hepatic blood flow. So think about how that specific problem might impact the clearance of other drugs you're giving at the same time. Drugs like fentanyl or propranolol, whose metabolism depends entirely on good liver perfusion and oxygen delivery.
That's a crucial link to make. The sources show halothane does impair the clearance of those drugs, prolonging their effect. Making that connection between the macroscopic hemodynamic failure and its microscopic pharmacokinetic consequences, that shows a really deep level of understanding.
It's a perfect example of connecting the dots. Review those numbers, master the hepatitis distinction, and you'll be in a great position to nail this topic on exam day.